Starting. We are here and beginning. All right, let's go on from here. Sure, this is off. This is off. That's off. All good. So I'll do a quick review from where we started before, or where we left off before, rather, and that was the gonorrhea aspect. So again, we'll retrace these with Nestor because they sort of bring together bacterial, viral, based on the presentation. So these are drainage disorders being characterized by urinary tract drainage, and at least it's a signal, and it's culturable, it's identifiable. You can look at it microscopically. It tells you things. Everything tells you something from a diagnostic perspective, and wherever your role is involved in this, or if you're not involved with it at all, and it's something on a personal or interpersonal level, it tells you stuff. So again, the interesting thing about gonorrhea, certainly not gone away, but not again. I constantly think it is because of the pain and the very identifiable discharge. Even though it is true there are a number of cases that are asymptomatic, yes, it's most often. The problem is if it's not recognized quickly enough, which is much more common in women than in men, then it can rapidly ascend and it adheres to everything. Very, very much so. And there's a lot of scarring. It's very much that kind of a disorder where there's damage to the tissue. And it's bizarre. There are cases where wherever there has been any type of sexual contact, so it's not just limited to anogenital or oral or anything like that. If you can think of a place, it's been there. And as well, when it gets into the bloodstream, it's able to certainly adhere and cause a lot of problems with joints. So it's really it's one of those little hidden things that when you're a clinician, in other words, you see these things. Septic arthritis in someone without a history of trauma is always the first thing you have to go is gonorrhea. And mucopurulent, painful urination, salpingitis, we covered that. This is the PID, which unfortunately I'm sure you're still going to see. But when it ascends to this level, then you know that there's going to be some significant complication for that individual down the road. So there's a lot of significant consequences, not just limited to joints, but and arthritic changes, but even something as bizarre as this. Remember that the leading cause of bacterial meningitis is in the same family called Neisseria species. So Neisseria meningitis is the first cousin, if you want to think of it relative-wise, of the very, very famous gonococcus. A lot of problems, particularly during the birth passage. This is the whole idea of now neonatal eye drops that replace silver nitrate, which was used forever. Gram-negative diplococci, very distinctive, attachable, but by way of the fimbriae, antigenic variation, a lot of things as you sort of scroll through this. So we're not going to go crazy over it. Strictly human, all over the place. That's a lot of it. I realize this is worldwide, but it means that it's certainly there, and you can see the way it is. Difficult to cultivate, no vaccine, but eminently treatable. Okay, and a lot of times we see different combinations. Like I said, when you see one, you always have to be on the lookout for two. One genitourinary infection, because of the nature of that system, really predisposes you to another that are there. Very interesting note to start with chlamydia. This is much more common, the most common reportable infectious disease in the United States. By far and away the most common bacterial sexually transmitted infection in the United States. For years, we didn't really have a way of calling it chlamydia. We didn't have testing. You know, when I first started in this, we classified everything as either gonococcal or non-gonococcal or non-specific. This was, once we had the technology and the molecular methods to be able to visualize these structures with the electron microscope and mostly by a variety of kinds of testing. It's not easy to see. It's very, very tiny. It can be a lot because a lot of these cases are not reported necessarily. The fact that it's reportable doesn't mean everybody reports it. And that's probably true it, I don't know necessarily, not having ever been someone who is responsible for reporting these things. I think for you, many of you in nursing in a facility, you have to, you have to report this to somebody, let them make the decision. You're not going to be the one doing the report, but I think it's worth, if you're going to chart it, you have to chart it. Well, let somebody else do it. I don't want to fall on my hand. How they do it. In a private practice, a little bit different. For years, doctors have been careful with what they put down in medical records. There's so much interaction that goes on and things like that. I don't know if it's necessarily right or wrong. It's a lot of these are judgment calls, I think. I was fortunate was not in a field where I had to deal with reportable infections very often. Dealt with a lot of infections, but not the reportable type. Okay, actual infection rate higher. Lots of them are asymptomatic. Very tiny. Why it was so hard? It lives inside of the cell, and that is interesting in and of itself. That made the discovery. Okay, and they actually have two different forms, which are interesting, that are there, and you'll see them go through this. One is it's sort of a form where it's active and infecting cells, and the other one's where it's relatively quiet. It's the active form that bothers us. Inflammatory mimics gonorrhea, same kind of deal with all of these types of things. PID can be a sequelae, as you can see. Look at the number in women, 75% asymptomatic. By the time it's PID, effectively, if you want to think of it this way, you're late. Okay, PID, acute, painful, asymptomatic, damage, etc. If it's not checked, there's other forms. Okay, some strains actually are. This is rare. In this country, particularly wherever the strain is lymphogranuloma venereum. Venereum implies a venereal disease or genital urinary area. And these lymph nodes get large to the point they're almost like filled with pus, and they're very unsightly that are there. Be filled with granuloma cells and large tender. It's that chronic deforming edema. You can see it's in other areas. Much more so. They seem to see an abundance of this in more tropical locations. And it's not the only, and the chlamydia trachomatis is not necessarily the only cause. The trachoma comes from the damage it did to eyes that were there, the keratitis and damage. And this is one of the real problems why it's so, the prenatal aspect of care for women is so important, to make sure that if they're going to be delivering vaginally, that there's not a problem associated with this. Eye infections, pneumonia also. So it's another one. And again, it's the type of thing, as far as I would think, absolutely preventable. Contact with maternal chlamydia is the most prevalent form. Antibiotic drugs or ointments are still the way to go with this if you're addressing it. But again, not everybody, depending on the circumstances, is this going to work. Here are the two different types. I'm not going to ask you about them, but I would note it for future reference. Again, particularly nursing boards, they love terms like this. Elementary versus reticulate body. The elementary body is the one that was taken up. That's the infectious. The reticulate body is once it's inside. Okay. And so the elementary bodies are released. They're the ones that are doing the damage. So that's sort of the life cycle. It goes from being active and invasive to being inside the cell and damaging. You want to think of it this way. Intracellular avoids the host cell response. It's got an unusual cell wall, very much like mycoplasma, in the sense that it's, even though this is technically gram negative, it really does not. Cell wall antibiotics have very, very little effect on this. Fortunately, there are other antibiotics that are very, very effective. Okay. So inflammation, cytokines, it's really the defensive responses, the damage, and that's frequently the case. So it's not direct, it's somewhat indirect, if you want to think of it that way. All the things that go on, human blood distribution. Notice this, adolescent women more likely than older women to harbor it, so perhaps it's a disease we see younger. Vertically and through sexual contact, we knew 50% of untreated babies born to infected mothers will acquire either the conjunctivitis or the pneumonia, and that's scary. Again, the detection now is more advanced techniques. That's why we didn't really have a way of doing it. We've got PCR and ELISA techniques. They are sort of indirect laboratory. The PCR is a very distinctive test. We're analyzing the genetic. We actually do some PCR here. The ELISA we do here also. Okay, but so those are much more, and obviously it's less accurate for females than males. When you're contacted, you're going to say the same thing. Annual, a note. I think you have to be cognizant. It doesn't have to be just women. And I think that that's a misstatement. Anybody who's sexually active and has unprotected sexual activity, at some juncture, you ought to get yourself checked on periodically. I'm not preachy about this. Do what you're going to do to anybody who's out there. That's your choice. Okay? I mean, there's consequences. All choices bring consequences. This is one, at least, if not preventable, at least hopefully addressable. Those kinds of things that are there. I mean that sincerely to anybody. I would, again, I am an authority on these things. I mean, only I could be an authority on that. I don't know about how many people whose daughters had their first baby before they were 16 years old. So I certainly am, judge that in the commentary that I make about how smart I am about this stuff. Okay. So there's a great line. Any fans of Indiana Jones? In Indiana Jones and the Last Crusade, that was around 1986, was who did it with the late Sean Connery. He said, choose, but choose wisely. I always think about that. So, Z-Pak, fibromycin, co-infection should be assumed and treated, rechecked, regular basis, treatment of partners. That's the difficult nugget with regard to reportable and things like that. Repeated infections, the likelihood of sequelae. We talked about this a little bit already because I went over the Nestor PowerPoint, because they are considered drainage disorders. These are the non-sexually transmitted, the itis, okay, itching, depending on the agent. Typically, it could be bacteria. Yeast infections predominate. Vaginosis being because it's less inflammatory. That's the one with a variety of organisms, possibly anaerobic. The unpleasant odor that can be very stigmatizing is also part of that. So when fungi give you trouble are dimorphic. They change from the yeast form into the hyphal strands. And the trouble is they're passed easily as yeast. When they form the strands, particularly in the lung, they cause a lot of problems that are there. They're typically all over the place. We have them. Yeast is easily detectable with any variety of prep, methylene blue, gram stains, pelvic exams, what they call pseudo-hyphae. These are not really classic hyphae. They're called pseudo-hyphae if you get into the fungal aspect of things, but they're partly diagnostic. Okay, not invasive per se. So it's not something that is likely to affect people under normal circumstances unless the reason is the suppression of the lactobacillus or suppressing some immunological thing. I get the version of this in the mouth periodically called thrush. Okay. Hospitalized patient in the bloodstream, not typically from vaginal infection, when we see systemic candidiasis, AIDS patients. Okay. Opportunistic, mechanical disruptions, always disruptions in normal bio. This is the most common by far away, broad spectrum antibiotics, menstruation sometimes. There's certain circumstances. I think it's less likely to be transmitted sexually. I mean, then at that point, you'd have the other person's immune system would also probably have to be compromised to some extent. So, if we're looking at someone who's immunosuppressed, that would be a problem. Okay. Not vaccine, there's topical and oral. The azole drugs, like I said, I use fluconazole or diflucam. And that was part of the vaginosis is the one, childbearing years, non-inflammatory, the discharge and the characteristic odor and the likelihood of anaerobes that are there. And so there's a variety of ones that are there. Again, we really don't understand it so much that's there. The one we talk about a lot is Gardnerella, which is an anaerobic, and that's why the effectiveness of the treatment with metronidazole has been really very, very good. Okay, maybe associated, maybe transmitted, maybe not. Changes, trauma, if you will. Here's the Gardnerella number. Low pH is typically higher, so we're having irregularities in pH, which does some aspect of that affect or make the lactobacillus less effective. So we looked at all of these things that are there. Obviously, having to have folks who be treated appropriately. Again, I think, I don't know about the topical. I think the metronidazole, clindamycin is the other agent, has more side effects and is also useful for anaerobes. Very large player, a protozoan. Same treatment, metronidazole, because it's anti-protozoan. So it has a lot of usage in this particular system. It doesn't have a cyst form. That's a little bit, most of these protozoans have a cyst form, and protozoan cysts are very, very difficult to treat. It's like what your veterinarian looks for when he gets fecal smears. They look for eggs and protozoans and cysts. Cysts are tough to treat. Okay, so it doesn't survive long out of the host. It can very well be asymptomatic and sometimes big problems. Men less likely to have problems than women. The discharge is more distinctive in women than there is. And there's sometimes microscopically, you'll see little bits of movement because these are characterized. We characterize and identify protozoan by how they move. Rotifers, they spin around. Remember, look at pond water when you're in high school, spinners and swimmers and all those, that's where they come from. And this is a flagellated one, so it uses that tail, and so it's flagellar-like motion. All the usual problems that are there. More susceptible. It's a recurring theme. Easily transmitted, not so much about the opportunistic shifts. It's just there. It's that kind of common. Okay. And so that's another one. In the male, this is prostatitis. This is non-sexually transmitted. It's more common in the male. I'll put it in for the sake of completeness. It's typically bacterial and mostly has to do with men as we start to develop problems. It doesn't necessarily mean cancer. It's just your prostate becomes harder, firmer, if you will, and more prone for things to get trapped in there that are there. And obviously hygiene could be impactful of this. They don't necessarily respond that are there, etc. You can culture away like things like that. This is really, and this is a consistent, so it looks consistent with the other urinary tract things. Pain on ejaculation, blood in the urine, difficulty, frequency, etc. Normally the treatment with Cipro or levofloxacin, which are in the same category that are there. That's typically the approach that you take. If it doesn't respond to that, then you have to look more at the prostate itself from a surgical perspective, and having just had that within the, a year and a half ago. Well, not a picnic. The next way we classify them are ulcerative. There are many more vivid pictures that you see associated with this. Be prepared, and for the handful of you out in virtual land. Years ago, back in the World War II and Korea days and Vietnam days, they always showed the military, the army, and the military people these training pictures about what they could get into trouble if they were on leave. You get my drift. Okay, so that's where these pictures came from. Syphilis, chancroid, very rare in this country. Genital herpes, ulcerative diseases. Infections with an ulcer increase the chance of infection with HIV or anything else because you have a barrier that's disturbed. That's the problem with this. It's multifactorial. So you have so many there. Syphilis is interesting. If you think back to Lyme disease, these are, and a little bit with that leptospirosis, which you saw early in this. Those are spirochetal diseases. Spirochetal diseases consistently have multiple ways, and they typically work through your immune system. They have an initial stage where they typically form something Then they quiet down, then they spread throughout your bloodstream or through other structures. Then you have a secondary phase that gets worse, and then frequently a tertiary phase which is almost no coming back from. That's very much syphilis. Syphilis was something, there's a wonderful, don't know if it's still on, probably is accessible, where they showed some of the effects very graphically which was originally on Cinemax, which was HBO's property, so that's why they're going to call HBO Max now, called The Nick. It was about a turn of the last, around 1900, hospital, and they were showing people where syphilis was rampant, and how people, when they got this and didn't know about how it was like leprosy, body parts were coming, and very much like that. These late stages of tertiary syphilis, things would just start to go. So it was really horrible. So primary is the classic. It's called something called a chancre. In the old days, now we call it a chancre. They used to call it a canker. My mom and dad, when you had like a cold sore, they called it a canker sore because they'd heard the term. For whatever reason, they called it canker rather than chancre, which is the way to pronounce it. So and that was the sign of primary syphilis. And there's good news and bad news. It's a very distinctive sign. That's the good news. And sometimes it's not necessarily painful. It's obviously much more visible in the male and sometimes not in the female because of its location, which could be more internally placed. The bad news is, and here's the other news, in about 3 weeks it goes away. And when something goes away, particularly if something that you don't want to go have treated because they might tell you something you don't want to hear, you think, I'm all better. But you're not. Now, the teeming with spirochetes that go through the bloodstream and start to have an immense immunological response. And all of a sudden you get what's called secondary syphilis, which has typically a rash, usually at least on the palms and soles, tremendous amounts of illness. We call it a great masquerader because immune systems, it's very much like mononucleosis. Swollen glands, feel lousy, stomach, hard chest pains, difficulty, the whole 9 yards. It could be anything that's there. And then magically, it goes away. And it goes into a latency stage where it has embedded itself in organs and begins to cause damage in characteristic organs. And it goes away and sometimes is absolutely invisible for, are you ready? 10 years, 20 years, 30 years. And then it resurfaces as something called tertiary syphilis, and now that's a fatal disease, mostly associated with insanity. The reason they had insane asylums when they were started to be formed back in the 1800s was mostly for syphilitic patients. They treated them with mercury vapors, which were toxic, and the lesions, the sores would go away. Then they'd come right back in the 1800s. And finally, they started putting people away for this because they were going crazy. And that was just part of it. Then you saw these stages where parts started to fall off, called gummas, and you start to see eye changes that were very characteristic, and all sorts of disorders. And there's not everybody progresses to that. The spirochete is in the lesion and in blood cultures, primary and secondary, and is transmissible, also treatable. Relatively easily treatable because your old friend penicillin basically still works. So it's the classic example of something that's impossible to grow. The harder it is to grow, the easier it is to treat. So we can't grow syphilis in culture. You can't grow it in a laboratory. They have tried for 100 years, more. So things like that, I mean, if you show it a picture of an antibiotic, it'll probably die. At least it'll be very frightened. Okay. Even that's called the latency period is treatable. As you begin to ascend in years from when the secondary, then it becomes refractory to any kind of treatment. Non-transmissible, latent, and tertiary. Voila. So the appearance of the hard chancre is different. There's a soft chancre that's part of chancroid at the side of the entry. Painless, depending if they're inside, you don't notice them. 3 to 6 weeks they heal. They probably start to surface a week or two after the initial contact. And that was another problem when people were very sexually active. It was very hard to trace. Then it goes into the circulation where it's very, very active. And so 3 weeks to 6 months after the primary heals, you've had widespread invasion, fever, headache, sore throat, lymph nodes, the rash that's kind of interesting looking. And there's some pictures that I have on the other PowerPoint. All of the sores, even in the rash, have viable spirochetes, lingers for months or years. 30%, 20 years, antibodies to the bacterium, and this is what it's about, immune response, are readily detected, but the bacteria is not. And then we don't see it a lot because once it has been identified, the antibiotics are very efficient. But years ago, they didn't. And the late stage changes in the heart, small arteries in the aortic cell wall. So you have ruptured aortas, valvular damage. These are the gummas. These, which typically skin, bone, cartilage, but also the liver. They're benign, okay, more or less, but they're functional and cosmetically really troubling. And the big problem is before that stage, when it's gone away, in secondary or in the latency period, you're still very contagious. And one of the real problems is if someone has been infected and they become pregnant, or if they were pregnant and became pregnant and were not treated previously, it crosses the placental barrier. And this was a big problem. We used to see it in kids. Congenital syphilis. Anywhere in the trimesters, disrupts development, mild defects all the way to spontaneous miscarriage or stillbirth. Infants, typically the doctor who described it was named Hutchinson. And so he had a triad. And so it was a Hutchinson's pupil, or an Argyle pupil, which is an irregular pupil. And then you had skin changes and you had bone changes that were associated with, and some other kinds of defects that were there. I don't recall exactly what, we don't see it that much anymore. But there were things like they'd have a nose that really didn't form. The shins, which usually are sharp, called saber shins, because they were that kind of sharp. They always had the eye damage. So there was quite a lot. So the late form gives rise to an unusual assortment in the bones, eyes, inner ear, joints, and the teeth. Hutchinson's teeth are like the teeth come out with little notches in them. So it infected a lot of what we call hard tissues that were there. It's called very famously Treponema pallidum, gram-negative, microaerophilic, strict parasites, only grows in living things, multiplies and penetrates anywhere as a target. It's only with us, lucky us. Easy to kill. It's to survive even in stored blood. The risk of infection from an infectious sexual partner, that's pretty high. For instance, your risk of getting becoming HIV positive from a blood splatter or a splash with someone who's just HIV positive is probably 1 in 500. It's a little bit different if they have AIDS. So when antibiotics came into play, everything changed. Okay. Interestingly, started to see an increase. I told everybody we screened for that. That was the reason for the premarital blood test, not to prevent somebody from getting married, but to track syphilis. And I don't know when that stopped here. Like I said, my first marriage, 1978, yeah, blood test, Pennsylvania. There's the spirochete that there's lots of different ways to look at it. Normally, you're looking at, we have different kinds of reagents that act like it. Okay, there's a lot of different tests where they use different things that were antigenically identical. In the laboratory, you would do, and it was when I matriculated. I don't know if they would ever do something like this today legally, but when I transferred from Lehigh to Seton Hall University, which is a Catholic university, Jesuit, in New Jersey, we had to have a syphilis test for entry. Thankfully, I passed. Because it also would have been a very interesting issue with my first wife. to say the least. Okay, and public health, contacts, blah, blah, blah. Prophylactic penicillin, barriers work effectively, no vaccine, mercurial, this is the mercury aspect, this was, we told you about early on, salvation with an arsenical compound, okay? But the toxins were so bad, they were real problems. So current recommendations, also utilizing a fair amount of CPRO and related substances. Chancroid, not that common, to tell you the truth. It is tropic and subtropical, sometimes appears here. It's ugly looking. It's got a fancy name, which I won't ask you about, Haemophilus ducreyi. Directly contacted. It has a lot to do with hygiene, has a lot to do with tropical condition. It has a lot, and it's just so tragic. I'm getting preachy. I hate the term sex workers. I realize legality, Nevada, prostitution is legal, fine. There's so much trafficking that goes on. It's just awful. That's just me. I'm editorializing. More. You're having fun here. See, it's awful. I haven't even gotten to the pictures. But you've been such a good audience, I think I'll have to show them. Multiple presentations. Okay. A lot of times these are not noticeable. Sometimes just itching or burning. And what's noticeable, and it's usually the first infection is the worst of these. So herpetic infections, single or multiple vesicles, almost anywhere, wherever the contact is, filled with clear, so it's a tiny blister, painful. This is the first, less so subsequently when recurrences, doesn't mean they're not. And sometimes, and that's the watchword, may, not feeling good, appetite, fever, swelling or tenderness. Again, it's worse during the first outbreak. So the initial infection is really the severe one, and again, there used to be a horrible series of pictures on this particular PowerPoint. I think they did away with, but I could probably find them. Okay, recurrences, because it's a herpetic virus, it's latent. We talked about that at length. Less severe than the original, but it could be. Some folks never have them. The best thing about Valtrex and the other members of that family, it's not preventative. It only works on active. No antivirals work to prevent. Vaccines, if they're effective, work to prevent. Antivirals treat once you're infected. But because it's activated only in cells that already have the infection, it minimizes the side effect. It reduces the number of recurrences. It reduces the severity of recurrences. Okay, some folks, they never recur. Sometimes they're constant. Depends. It's very poorly understood. Okay, typically asymptomatic or surface, not really problematic. As you can see, it's rare to get herpetic infections. I remind you, my daughter had effectively a viral meningitis that was herpetic in origin. Think of a cold sore where it went in the wrong direction, the nerve went up and affected the meningeal. She responded well to acyclovirs, but she had to be hospitalized for a bit. This was more than 10 years ago. So, so you can go in the wrong direction if you want to think of it. And this is what she had: headache, stiff neck. And fortunately, MRI showed that it had not gotten to the stage of encephalitis. It was still at the meningitis, which is much more treatable than the bacterial. The neonatal one, extraordinarily dangerous. And it's typically if there's a primary genital herpes infection at the time of the birth, contaminated by mothers immediately before or during birth, perhaps hand transmissions of lesions to the baby. I didn't know that was true. So with a history of recurrence monitored, so you would absolutely, during those last 4 weeks, okay, If no evidence of recurrence is seen, vaginal birth can continue. Any evidence of outbreak would be C-section. That's a typical lesion that you see that's there. It's thought of the virus that infects the oral mucosa, typical culture. HSV2, we talked about that, genital versus oral herpes, very similar. Either virus can infect either region depending on the type of contact. And you don't have to get graphic about it. Everybody, there's so many different types of intimate contact that we have. So literally anywhere. So latency maintained within sensory nervous system cells. It creates microRNAs, all these different things. Other infections, ultraviolet light, injury, menstruation, stress that are there. 4 billion out of 7.7 people are infected worldwide. That's a lot. So take you, most likely we were all exposed in some way, shape, or form. I mean, if you ever got in a cold sore, you got it. Okay. And when you get to the HPV nugget, same deal. Once you have it, you have it. It's not something that goes away. They're consistently latent. Transmission, direct exposure to secretions, active lesions, most common, even without, because sometimes it's going away and you don't see it, and sometimes it's coming out and you don't see it. More common than chlamydia and gonorrhea, but is not a reportable disease because there's nothing we can do. Don't even know it. Vast majority of people are asymptomatic. Characteristics, you can test. Most time the diagnosis is based on its visual appearance. No vaccine necessarily available. Who knows? Again, the interesting thing about condoms, particularly, it's always where is the lesion. It doesn't, if it's not there, if the herpetic lesion, or for that matter, the wart is not covered, it's not going to do any good. Okay. Several agent, non curative, acyclovirs, talked about, and then HPV. I still think this is the most common. I do not know if they're going to have numbers here or not. What I didn't tell you about when we did this initially was when we did skin, is I usually do skin, I usually do warts a couple of times. When we do the viruses initially, first one we look at. Okay. Human papillomavirus. We usually do it in genitourinary, and we do it here. And here is skin, is here. And then we also do it in skin, which I forgot to do. Okay. So you can be infected without any problems. The wart basically is a skin disease. It's a kind of a tumor. It's a tumor-inducing virus, an oncogenic virus. And remarkably, they're almost always benign on the skin. Not always. Okay. I biopsied a few that were suspicious over my years. And every time I removed a wart, I send it in for an hour. Every single time. So if I removed 1,000, one or two had findings that were questionable. And you just monitored the people appropriately for that kind of thing. The reality is, if the warts look irregular, my index of suspicion goes high. A wart on your skin, if it's not on the bottom of your foot, it kind of heaps up. And it's got a distinctive barrier around it, which is a capsule, which is good because encapsulated lesions don't spread unless it's something called a pseudocapsule. Okay. On the bottom of the foot, they don't grow out, they grow into the skin. People always think it's growing into the bone. No, it's not. It's confined to the epidermis. I mean, if it's big and thick enough, it's going to make your bone hurt if you're walking on it, or if it's on a hand that you're using for work and the wart's there and it's pressing on deeper structures, it's going to irritate it. But it's strictly an epidermal lesion that's there. And they're relatively easy to treat. Will they recur? Sometimes they do, sometimes they don't. Anybody can get them. I had one here 5 years ago. I have no idea how it got there. Probably touched something with a virus, scratched here, effectively inoculated into my skin. She's my family doc who retired, just got the old, the liquid nitrogen out. See, my wife really enjoyed watching him do that. There were issues. She goes, I'm going to use liquid nitrogen. She goes, I'd like to stay. You be watching. Okay, so and they look more irregular, like clusters. We call it filiforms. So rather than being flat or like little cauliflower mounds, they kind of got little, bumps and sort of like it looks weird. Okay, vulvovaginal area, males almost anywhere, penis and scrotum, perianal, groin regions. So they can be tiny, flat, and inconspicuous. The ones that we see this one, and I've seen these in more than one place, called condyloma acuminata was the fancy name for it. So they branched, that was the cauliflower-like, and it was interesting. Sometimes they can even be obstructive if they're periurinary, perianal, periurethral, like that. The cervical ones are really the significant, and there's so many different types. There's a limited number of types that are part of this. And there's more information from the other PowerPoint, specifically about what types are commonly involved in Gardasil and the other immunizations that have been, to my understanding, more or less successful, but limited time-wise between roughly maybe as early these days as age 11 through early 20s, because the likelihood if the person's sexually active, they've been exposed. It's reality. And it's up to you what your feelings are. A lot of parents were reluctant because they thought it would be, well, if they have this, then my kids will be more encouraged, But the reality of biology, I've always said, again, the authority that I am about my daughter, that biology is a motivator. If they're going to do it, they're going to do it. Period. In a sense. You're not going to be able to watch them every second of every day. It doesn't work. And so that's the vast, immense amount of cancers. So maybe this is a 4-year-old statistic. That's a ton of women dying from this. Males, it's not exclusive to women. So all of these are typically effective. It's less common. It still occurs. So because the skin, the penile skin, the perianal skin is much more a tendency to non-keratinized. It's more like non-keratinized stratified squamous than keratinized. The keratinization is what distincts it. A tremendous increase from oral sexual activity, tremendous amount. The largest single area. Interestingly and upsettingly, the largest area statistically for a long time was middle schoolers, as sort of a first exposure to, intimate contact. Non-enveloped DNA, naked virus. Popova was papilloma, polyoma, vacuolating agent was where it got its name when I first learned about it. Now we have human papilloma, we have polyoma, and there was one called SV40, which was simian virus 40, which because they found it in members of the, I want to use a politically correct term, monkey family. Shut up. Seed warts, flat warts. If it's a wart, it's HPV. So here's the difference. 5 types associated with cervical anal cancer. So these are the ones, 16 and 18 I knew about. The other ones I did more information. Other types can put you at higher risk as well. Typically how these work, and we looked at it a little bit in the viral chapter. There are 2 things. They're oncogenes. An oncogene is a gene that you have that's inactive. It's in the off position. When the virus becomes latent, it basically it stops it from the off and flips it to the on position. And you might remember using the analogy, it's like turning on the accelerator and you can't, it's like puts the accelerator in drive and you can't do anything about it. The other genes they affect are called TSR, tumor suppressor genes. And tumor suppressor genes are like your brakes. They're normally active. And so what happens is your brakes don't work. So if you have stuck in it, if you're stuck going forward and you can't brake, an accident's going to happen. So that's and all of these lead to basically that's the accelerator for the cell cycle and the brakes that are on the cell cycle. So nearly all sexually active adults will get HPV at some times in their lives. 14% of female college students become infected with this incurable condition each year. Direct contact, auto inoculation, like I said, you could just get it on a fingertip because you touch something. It lasts a long time on surfaces. Indirect transmission, but is more common for non-genital warts caused by HPV. So that's usually what we used to see. That's the typical part that I did when I talked about it in skin, is like when you had burlap mats going out to the community pool or the pool at the Y. Now they have they're like they're nylon type ones that have like a little thing stick out so they're non-skid. It's on there. It's on there. The burlap was worth because it abraded the skin. But that's what we had at all the pools, whether it was the community pool or the pool at the Y or wherever it was. Screening, pap smear is the best screening test, absolutely. Nearly all precancer cells have conducted on the recommended, whatever the recommendations are. 9 types, youngest 9. Why am I troubled by that? I still think statistically, vaccines have their limitations as well. Even with the vaccine, cancer can result not included. Slow in developing, the screening, the pap smear, okay, and whatever the guidelines are here, which I don't go into. Incurable, it can resolve, and you may never get it again. And there's no method. All they are methods that cosmetically remove it. You can excise it. You can. I did what's called curettage and quarter. I'd scoop it out and I'd cauterize it with, in my case, electrical current. I shot sparks at it. And let's see. Oh, let's stop here. I do want to spend more time with molluscal contagios. And we'll have pictures. Aren't you excited? You're terrible. At some juncture, I'm going to do a review for the final thing.